Hi, everyone. I'm Jean Meserve, and thank you for joining us today for our eventcast, People v. Cancer. This is the third and final episode of our People v. Cancer series. Today, we're going to illuminate stories from the front lines of the cancer community. We're going to talk about science and about the power of the human experience. Over the next 2.5 hours, you're going to hear about a number of topics, including the mental and emotional impact of getting a cancer diagnosis. We're also going to talk about the latest diagnostics and the latest treatments. We want to remind our viewers that we want you to be part of the conversation, whether you're watching on a computer or on your cell phone. During select sessions, you will be able to ask questions using the chat function that you'll find at the bottom of your screen. Please keep your questions short, keep them on topic, and let us know where you're watching from. Before we get going, we would like to do some thank yous. We'd like to thank our founding underwriter, Bristol Myers Squibb, and our presenting underwriter, Amgen Oncology, for supporting the Atlantic's journalism and making today's program possible. And now for our first conversation, I would like to introduce Julie Fleshman, who is CEO of the Pancreatic Cancer Action Network, for a discussion about the latest in the fight against pancreatic cancer. Julie, thank you so much for being with us here today. And let me
Thanks, Jean,
remind
for
our
having
viewers,
me.
my pleasure. Let me remind viewers that for this session, you can ask questions, so use that chat function, as I mentioned earlier. Every year, 50,000 people are diagnosed with pancreatic cancer. 45,000 people die from it. Just in the last year, we have seen the deaths of the iconic civil rights leader and Congressman John Lewis, the death of Supreme Court Justice Ruth Bader Ginsburg, and also just 2 weeks ago, the death of the iconic host of Jeopardy, Alex Trebek. All tragic losses, but Julie, I'm wondering if these high-profile deaths have brought a focus to pancreatic cancer and whether you think that's going to make a difference.
Yes, thanks, Jean. Yeah, definitely these high-profile individuals, when they are diagnosed with pancreatic cancer, raises an incredible amount of awareness and visibility. And it's pretty astonishing how many iconic figures were diagnosed and died this year from the disease. In particular, Alex Trebek was so generous with sharing his very personal story about his journey with pancreatic cancer with the public and talking about the ups and the downs. And that just raised so much visibility, as well as just providing hope to patients and families that are currently battling this disease, knowing that they're not alone, that someone like Alex Trebek is experiencing some of the same challenges.
You lost your own father to pancreatic cancer back in 1999. Do we know a lot more about it now than we did then?
Well, we absolutely do. It's actually pretty amazing, I think, how much the field has grown over the last 20 years. 20 years ago, there really wasn't a pancreatic cancer research community. And today, there's a vibrant, robust, growing field of researchers that are focused on this disease. There are also very few dollars being invested in the disease. And the reality is that science follows money. So one of PanCan's early strategies was both to fund junior investigators to encourage them to come into this field and make pancreatic cancer their career focus, but then also to raise funds and advocate in Washington, D.C. to increase the resources that are available to the pancreatic cancer research community. And although we certainly still have a long way to go to improve patient outcomes, the foundation that's really needed to accelerate progress now exists today. I'm proud that PanCan, I think, has played an important role in really building the field and getting us to this point.
Pancreatic cancer is still the third leading cause of cancer deaths. Why is it so deadly?
So pancreatic cancer is a challenging tumor. One, your pancreas is located in the middle of your body. It's in your abdominal cavity. So you can think if you were going to hide something somewhere in your body, you would hide it in your pancreas. It's this small little dark organ sort of there in the center. There is no early detection test. So it's not something, we can't feel our pancreas like we can potentially feel other types of cancer tumors. And there is no early detection test. And unfortunately, the symptoms for pancreatic cancer are also quite vague. There are things like lower back pain and stomach pain, unexplained weight loss, things that can also be associated with other diseases. So people don't always, move immediately to think that it might be pancreatic cancer. So usually by the time the disease is diagnosed, it's late stage, it's already metastasized or spread to other organs, and then much more difficult to treat at that point. And then also just we need more of an investment in funding the disease so that we can both find an early detection test and also advance new treatments for patients.
Is there progress towards a detection test?
So there's certainly a lot of work being done in the early detection space. Biomarker, a lot of different companies as well as academics are studying biomarkers that could be something that would be an indicator for pancreatic cancer in the early stages. So there's lots of different strategies being explored. One of the issues is that in order to validate a biomarker, you actually need to identify a group of people who are at a higher risk to get pancreatic cancer than just looking at the general public. And so one of those groups of people that is at higher risk that we've learned recently through research studies is that those people who are new onset diabetics after the age of 50, that new onset diabetes for some of those people is actually an early symptom of pancreatic cancer. And so now what we need to understand is how do we identify those people where it's an early symptom of pancreatic cancer versus those people who it's just, regular diabetes. And so as an example of one, study, PanCan is funding an early detection initiative looking at this cohort of new onset diabetics. You have to follow a lot of people, all across the country. And then with that group, you can validate biomarkers to see if, does this biomarker actually indicate that this person we think that's going to get pancreatic cancer, that they actually do. So, I think there's a lot of interesting and exciting work being done in this area. And again, PanCan is proud to be funding some of this central work.
With no diagnostic or detection test ready at the moment, how is it usually found?
So many times sometimes it's found because somebody's gone in for something else, and they discover it. That's if someone's having surgery for something else and they discover the disease that way. Usually that's a good thing because it's usually then diagnosed earlier. But for the majority of the people, people go in, they're complaining with some of these vague symptoms that pancreatic cancer presents itself with. And then patients might have a CAT scan, they might have an EUS, which is an endoscopic ultrasound that goes down and actually takes a biopsy out of the pancreas to confirm whether it is pancreatic cancer or not.
Where are we on treatments?
So there's, I think this is an area to me that's exciting. There's a lot, we have a much better understanding of why pancreatic cancer, the tumor itself, is so challenging to treat. And so now with that knowledge, researchers are really able to focus in on different treatment approaches. So some of those treatment approaches, we've actually made a lot of progress in the last 5 years or so on personalized medicine. And what role does personalized medicine play in pancreatic cancer? 5 years ago, nobody knew whether better understanding basically the genetic alterations in someone's pancreatic cancer tumor. If we understood that, does that then better lead us to identifying the right treatment option for that patient? And what we've learned over the last 5 years is that it does. That if a patient has an actionable alteration or an actionable genetic mutation, and we're able to target that that mutation with targeted therapy, that those patients do better. So that's one exciting area. Immunotherapy is another hot area that there's lots of work being done in pancreatic cancer to better figure out how can we better understand inflammation and the role inflammation plays in pancreatic cancer, and then use that information to develop immunotherapy drugs for pancreatic cancer. And then, the last area is we have a better understanding today that the pancreatic cancer cells are different than cells in other cancers. How they get their energy and how they sort of feed the tumor is different. And so that's more, knowledge that can be used to then really target treatments that can help attack the cancer.
But at the present moment, no cure.
Unfortunately, there is no cure today, but there are options, and I think that's a really important message. PanCan recommends that all patients consider clinical trials at diagnosis and throughout their journey. Clinical trials are the only way that we're going to advance new treatment options for the disease. And there are many open and enrolling pancreatic cancer clinical trials all across the country. And people
And
can
how do
call
people
our
find
patient.
those?
Yep, great question. So PanCan has a call center and a tool that houses all of the pancreatic cancer clinical trials that are open and enrolling around the country. And we have case managers that can help identify clinical trials that might be right for a particular patient.
Your organization has started something called Precision Promise. Explain to us what that is.
So, Precision Promise is an adaptive clinical trial. So, one of the things PanCan's looked at over the years is why aren't we making advances as fast as we would like in terms of finding new treatment options? And the traditional clinical trial system is not a fast system. It requires a lot of patients to determine if something is working. You only can study one treatment option at a time. It costs a lot of money. And so PanCan really looked at this and said, can we change this paradigm? And so we've, over the last 4 years, working with over 100 pancreatic cancer experts, have developed Precision Promise, an adaptive clinical trial, which is a different model and design for drug development. We've worked with the FDA. The master protocol was approved last summer, and it will allow us to test multiple treatment options all at the same time. So you can win faster and you can fail faster, and hopefully accelerate the rate of progress for new treatment options for patients.
And is there sharing of data? Is there cross fertilization here between the different people who are doing research?
Yes, I actually think the pancreatic cancer community is a very collaborative community. I think this is such a tough and challenging disease, and there's been such limited resources that institutions and researchers are really willing to work together and to share data. Certainly, in all of the things that PanCan funds, we require that. We require, we want to make the data available to all researchers in anything that we're doing. And I think we've helped to create a culture in the field that that's really what is the best way to go move forward in order to improve outcomes for patients.
If this project moves clinical trials faster, why isn't it adopted throughout the medical community? Why is this unique to the pancreatic cancer research community?
So there certainly are other adaptive clinical design platforms. Pancreatic cancer is not the only one. However, ours is unique in that it is a registration trial, meaning that a drug can actually get approved through Precision Promise at the FDA. And it also has some unique things that we've put in place that are very patient centric. So, I think the bottom line is the FDA is very open to these kinds of new models and designs, especially for difficult to, treat diseases like pancreatic cancer. But it's really taken PanCan sort of being this unbiased stakeholder to bring together all of the different, the pharmaceutical companies and the researchers and the clinicians and the patients and all of the people that are, analyzing the data, all of those people together to say, we want to do this. PanCan has had to invest philanthropic dollars in order to make it happen. And I think that's, a role that patient advocacy groups play, is that we're good conveners in identifying sort of the big picture. What are the gaps? Who do we need to bring together? And then going out and raising money so that we can make it happen.
So give us your dream. Where do you hope you'll be with pancreatic cancer research in 10 years, in 20 years?
Yeah. So, I mean, I really hope that we will have an early detection strategy in 10 years. I believe it's absolutely possible based on what is happening now in the field. And I am hopeful also for new treatment advances. I believe precision promise will be an important part of accelerating those new treatment options. And, currently the 5 year survival rate for pancreatic cancer is only 10%. So we need to move that. There's a long way to go, but I believe in the next 10, 20 years, we can rapidly accelerate that. In 20 years, let's get that to 50%. Let's really make this a disease that many patients can live with, and have good quality of life.
And that's going to take more money, right?
More money, yes. Unfortunately, none of these things are cheap, and we need people to step up and help to support these ambitious efforts. But I do think they will pay off. We've seen the progress over the last 20 years from where we were to where we've come, and I can just imagine that rate of speed over the next 20 years, will be twice as fast. And so it's actually really exciting to think about where we can go with the right resources and the right support.
Julie Fleshman, thank you so much for being with us here today. We appreciate it.
Thank you so much, Jean. It's a great discussion.
And before we begin our next session, I want to direct you to a feature we're using this afternoon, polling. For those of us joining us on the Hopin platform, you can find it by clicking polls. You'll find that on the right-hand side of your screen. The first question is, who do you look to for answers and support on issues about cancer? We hope that you'll cast your vote and see how others respond too. And for our next conversation, let me introduce journalist and Atlantic Live contributor, John Donvan. John.
Thank you, Jean, my friend. I just learned so much from that conversation. So thank you very much for that conversation. And before the next one, I want to remind people who are watching that you can take part in the upcoming conversation, the interview we're about to do, by using the chat box to submit a question. And as Jean said, try to keep it short and on point. And what is our topic? Our topic is the emotional, the emotional and mental journey that cancer patients go on from the moment of diagnosis forward, given the uncertainty, given the fact that their lives have just moved into sort of an epic moment, and they are in the middle of that epic. And now we are in the middle of a pandemic. So we want to have a discussion about what those patients are up against emotionally and what can be done to help them. And joining me now in that conversation, I want to say hello to Walela Terefa, who is the Chief Medical Officer of the University of Texas MD Anderson Center, Shelley Turoger, Associate Director of Population Science at Moffitt Cancer Center, and Allison Applebaum, a psychologist at Memorial Sloan Kettering Cancer Center. Welcome to all three of you. I'll start, since you're the psychologist in the group here, Allison, just take us through I understand it's obviously different for each person. Everyone is an individual, but take us through the beginning of the journey that an individual has upon getting a diagnosis of cancer from the emotional point of view and the mental health point of view.
Sure. Thank you so much for having me. And as you just said, we are all unique as humans, and so the experience is unique across the cancer continuum, but there are predictable trajectories of distress. So at the time of diagnosis, we see an increase in symptoms of anxiety, depression, and even post-traumatic stress symptoms. And these make sense because cancer is life-changing, but if they're not addressed, they can become debilitating and very severely interfere with one's ability to actually engage in cancer care. And so treatment is very important. As the patient goes through their cancer journey and their treatment and enters ideally what we call survivorship, we actually see an interesting dichotomy between the emotional experience of patients and caregivers. So for many patients, they report having a new lease on life. There's a decrease in distress. They return to a new normal. But for caregivers, family members and friends who are so intimately involved in the care of patients, we actually see a significant increase in distress in survivorship. And this is likely because caregivers oftentimes engage in what we call fight or flight mode. They are focused 100% on patients during the diagnosis and treatment phase. And it's only when there's medical stability that they allow themselves to come into contact with many of the negative emotions that they likely were avoiding. And importantly, from a health systems perspective, this is the same moment when our families become disconnected from our healthcare system. What is common among patients and caregivers that you already mentioned is uncertainty. Fear of recurrence is a common complaint among all patients and caregivers in survivorship. And I think sitting with uncertainty is a key challenge faced by all as they go through their cancer journey, and perhaps now more than ever in the setting of this pandemic.
Dr. Applebaum, are there things that they can do at the beginning of this journey now, given sort of the heads up that you just gave? Should there be, are there already protocols in place, or that would address the pitfalls that are in front of them that you just laid out?
Absolutely. So I wouldn't be sitting here today if it was not for Dr. Jimmy Holland, who founded the field of what we call psycho-oncology that integrates psychiatry and oncology. And Dr. Holland not only founded the field and the first department of psychiatry in any cancer center in the world here at Memorial, but she pressed to recognize distress as a sixth vital sign in cancer. And she encouraged us all to recognize that in order to comprehensively treat cancer, we actually have to treat the patients, the humans with cancer. And so because of her work and her vision and her mission, all comprehensive cancer centers across the country have supportive services for patients and caregivers. So my advice is to engage in care. There are supportive services available for individuals, for groups, for families. And I should say, perhaps the silver lining right now in the setting of our pandemic is the fact that we are all providing care over telepsychiatry. Historically, there have been many barriers, understandably, to psychosocial service use. So the financial cost and time associated with traveling to our treatment centers, patients not feeling physically well, or caregivers feeling guilty for taking time away from patients. And what remains today, even in 2020, the stigma associated with mental health service utilization. The fact that I and my colleagues are able to provide high quality care over the computer screen, it really is setting a new standard for the type of services that should and can be available for patients with cancer and those who love them.
So you've pinpointed one silver lining from the pandemic, which a situation which has very few. But Dr. Terefe, I'm curious, given that now so many of us who are not touched by cancer, nevertheless, are beginning to have the first taste of an experience where we need to be careful about who we come in contact with. We need to be careful about where we go. We need to be wearing masks. Cancer patients have that set of challenges once they're undergoing treatment, particularly if it's chemotherapy. Do they not have that set of challenges all along and in great depth and potentially with much higher danger to them from what the environment might present?
You know, I think in general, people who are undergoing active therapy for cancer understand that they're vulnerable. The degree of vulnerability really depends on the type of treatment that's being administered. For example, people with blood cancers are often so highly immunocompromised that they actually need to be hospitalized during most of their treatment course. But other people with, say, solid tumors like breast cancer can often continue most normal activities. I think what we've seen here at at MD Anderson is that our patients have that heightened awareness and so have adopted those safety measures with great enthusiasm, including masking, distancing, hand washing, and avoidance of non-essential activities. It certainly has had some silver linings in both the outpatient and inpatient sphere. You know, every year we see our cancer patients being vulnerable to respiratory viruses like influenza, parainfluenza, and RSV. But because of these extra safety measures, we've actually seen an almost complete avoidance of transmission of those viruses towards the end of the last respiratory virus season, which coincided with the start of the pandemic. And we're seeing it now as well. And that is certainly a silver lining. But of course, as with all things, it has come with some cost. Part of the reason that our cancer patients have been able to avoid infections is because they're more isolated. They're more isolated socially at home, and they're also more isolated in the hospital. Like most other hospitals, we have severely restricted visitors to keep our patients and our staff safe, and that certainly has a tremendous impact on the sense of psychological well-being, the ability to take in information, the feeling that you're not alone, that so many of our patients rely on their caregivers and family members and loved ones to provide while they're receiving treatment.
So that's a whole nother front of emotional risk then, this sense of isolation. I think I hear you saying actually has impact on their on the way that they're able to take care of themselves, take in information, comply, etc. And is that a vicious cycle that those individuals are in due to this isolation?
I think whether the cycle is harmful really depends on the additional supports that hospitals and providers can deliver. We have been very intentional about making sure that we help our patients stay connected with their loved ones through virtual means, FaceTime, Zoom, those kind of things, whether they're in an outpatient appointment or they're hospitalized. We've also made sure that we've provided intensive support in terms of social work, case management, chaplaincy, and psychiatry so that people don't have to walk these things alone, even though physically they may be more isolated. I think, truthfully, where we feel less able to intervene is actually what's happening in the homes of our patients with cancer. We know that social isolation and economic insecurity both increase the risk of domestic violence. And we also know that people who have been living in an emotionally, verbally, financially, or physically abusive home see the intensity of that violence increase when they're diagnosed with cancer. And this has really created, I think, a perfect storm as we see data from around the country that domestic violence incidents have increased by anywhere from 10 to 25% in multiple cities across the nation. We know that that intersects very much with our vulnerable cancer patients who are at home.
Dr. Chu Roger, what we're hearing a description of are some very stressful situations, and I want to know what do we know about the impact of stress on the prognosis for recovery or survivability of an individual with cancer?
Yeah, that's a really important question, particularly now during the COVID period, where, as the other panelists have talked about, that is really increased stress that cancer patients already experience. We know that stress and distress can increase inflammation, and inflammation can make us feel worse. It can make our fatigue worse, particularly for cancer patients. It can sometimes make you have other physical side effects to your treatment, like nausea. It also may actually reduce your immune system's ability to defend itself against the cancer. So our own immune systems are a critical part of fighting off the cancer for cancer patients. And there are now studies showing that people with very high levels of stress may actually have reduced ability for their for their immune system to affect their tumor. So this is why it's really important to receive treatment if you're feeling distress, to reach out and access social services if you're having financial stress, or if you're experiencing any kind of emotional abuse or social isolation, to reach out and get connected to support groups and other activities that can help offset that stress and give you coping skills and mechanisms to help.
So those are available. And what I'm asking is, those tools really do make a difference. I'm thinking in terms of potentially somebody watching who's just at the beginning of this journey. That would be very encouraging to know that there's not just a phone call, but at the other end of the phone call, there's something that can really make a difference.
Yeah, there's more research studies now showing that engaging in support groups, particularly that help with social support and help give skills to cope with all of the stressors that come with being a cancer patient, can actually even improve survival. There have been several studies in breast cancer patients in particular that have shown that. We also know that it can improve quality of life in different types of cancer. That receiving those services can help you feel better physically and emotionally.
Um, Dr. Applebaum, do we need to be talking also about the mental health of the caregivers, people who are living with and supporting people who have cancer?
Absolutely. And it's perfectly timed. This is November National Family Caregivers Month. Caregivers have always taken on incredible responsibility for patients, and I think that responsibility is greater now than ever before. We're talking about isolation. Historically, caregivers can rely on extended family care networks, maybe, or home health aides or visiting nurses. And now, most are providing care in isolation, and many even from afar. So not only is the responsibility great, but they're doing it in isolation. We know that caregivers are at risk for their own distress, anxiety, and depression, and really are in need of support. I think we're recognizing more and more that if we are asking caregivers to play an active role on treatment teams, as they are, that we also need to provide support. So if you're a caregiver watching, the distress you may be experiencing, it's normal, it's appropriate, and I encourage you all to get support and to reach out to wherever your loved one's receiving cancer care. There are services available, likely just for you.
I want to share that in answer to our poll question, who do you look to for answers and support on issues about cancer? 86% of you, that's a big majority, answered researchers and medical experts, significantly more than the news media or political leaders. Dr. Tarafe, we have 1 minute in which I just want to take a question from Jenny Schrodera. 1 minute's a short time to answer this question, so think bullet points. I'd like to hear about the best practices for supporting cancer survivors once they move into the survivorship period. Now you only have 40 seconds because my question took 20.
One key is to follow their lead. People who've survived cancer know what they need when they need it, and it may change from minute to minute, but following their lead is the most important thing, whether it's distraction, whether it's activity, whether it's talking about what's happened. I think the other is being very aware of the serious financial toxicity that people with cancer deal with many months and years after they've completed treatment. And I think all of us can be advocates at the local, state, and national level to ensure that people with pre-existing conditions continue to have the insurance access that they need to be confident that they can be cared for long term.
All right, you really nailed it on that one. I want to thank you very much, Dr. Tarafe, Dr. Roger, and Dr. Applebaum. Thanks to all three of you. And now I return it to Jean.
John Dondan, thanks so much. Hundreds of thousands of women are diagnosed every year with breast cancer. What do we know about it? What don't we know? Joining me now, a co-anchor of ABC News 2020 and GMA3, What You Need to Know, both productions of ABC, Amy Robach. Amy is a breast cancer survivor herself. I'm also joined by Dr. Elisa Port. She is Chief of Breast Surgery at Mount Sinai Health System and also director of the Dubin Breast Center at Mount Sinai. Welcome to both of you. Amy, let me start with you. You discovered your cancer in a very, very public way. Talk to us a little bit about that and about your journey since.
Sure. So thank you for having me. And yes, I agreed as a part of an assignment for work to have a mammogram, my first ever at the age of 40, in a mammovan in the middle of Times Square on live national television on Good Morning America to let women know that this is a procedure that isn't that painful, that should be accessible to all women when they want it, not when a regulatory committee says you should have it. And so I thought I was being of service to other women. I did not have cancer in my family. My mom's one of 9, my dad's one of 6. I truthfully thought I was immune to it. And that mammogram ultimately led to a diagnosis of stage 2 invasive breast cancer. The cancer had already spread to my lymph nodes. I had 2 masses in my right breast. And so when that news came to me, I felt like it was my duty, honestly, to go public that mammogram led to a cancer diagnosis. And my hope was that it made women everywhere aware that cancer can happen to anyone. And while mammograms aren't perfect, they're what we have, and they can be a life saving tool. And I certainly credit it with saving mine and giving me at least the best opportunity for having a longer life and a better chance of surviving breast cancer.
And Amy, you're healthy now?
I am. I actually just rounded my 7 year from being diagnosed on October 30th, and I'm on tamoxifen. I am grateful for the drug therapy, targeted therapy that I have. I went through 8 rounds of chemo, several surgeries, and I have changed my diet. I have changed my exercise routine. I've changed how I live my life in every way, and I've never felt stronger and better. But every 6 months, when you're a cancer survivor, that is a diagnosis that stays with you forever, not just mentally, but also physically. You're going to the doctor usually at least twice a year for a blood test for tumor markers, looking for tumor markers. And so there is like a 6 month reset button at every point in my life where I think, okay, I've got 6 more months, let's live. And it is a constant reminder that no one's guaranteed tomorrow. And it's a constant reminder that our health, in part, is in our own hands and how we treat our bodies and how we treat others. I think it's all a part of our overall health. And so I'm grateful for every day, but I'm aware of how lucky I am every moment I have here.
Dr. Port, I had a friend contact me just this week with a breast cancer diagnosis, and I've read that 1 in 8 women will be diagnosed with this. Is it indeed an epidemic?
Hi, Jean. Thank you so much for having me on. And hello to Amy. We've done a couple of panels before. It's so wonderful to see you healthy and looking better than ever. And it sounds like feeling better than ever. Yes, breast cancer, I wouldn't use the word epidemic because epidemic implies kind of like what we're going through now with COVID, that it's spreading and it's growing and it's contractible from person to person. Breast cancer is not like that. What it is the most common cancer to affect women in the United States, with 1 in 8 to 1 in 9 getting breast cancer over her lifetime. For women who live to be the ripe old age of 80s, 90s, etc., and don't die sooner of other causes. So yes, it is the most common cancer to affect women in this country. We estimate that approximately 300,000 women will be diagnosed. And remember, about 3,000 men as well will be diagnosed with breast cancer in the United States this year.
So is the rate increasing then? And if the rate is increasing, do you have any idea why?
So the rates have fluctuated over time. And yes, we do have some ideas why. For a while, for example, the rate was increasing. And then about 10, 15 years ago, when some newer information came out, that hormone replacement therapy was probably increasing the risk of breast cancer, and it was stopped in a lot of women. The risk of breast cancer, or the rate of breast cancer, actually went down for a while. One of the things that can increase the risk of breast cancer, Amy was implying she's feeling healthier than ever and she looks phenomenal. One of the things that is a big public health problem in this country is being overweight and being obese. And obesity definitely increases the risk of getting breast cancer, number one. And number two, for women with breast cancer, can increase the risk of recurrence, unfortunately. So I think what's going on in this country is partly that. And I think, of course, there are other factors at work. But for sure, the risk and the rate is going up. Again, it had gone down previously, but goes up a little bit each year for sure.
And what about the survival rate?
So that's the good news, is the survival rates from breast cancer have never been better. And so despite the increasing number of cases, the treatment options and the early detection, as Amy was talking about getting mammograms for early detection, that has led us to an unprecedentedly high survival rate overall. For example, about 20% of the breast cancer that we diagnose today in 2020 is a subtype of breast cancer called DCIS, which stands for duct carcinoma in situ. This is also known as stage 0 breast cancer, and it's cancer, but it's cancer cells that are still contained within the milk ducts and really don't have any capacity for spread. This is about 20% of all of the breast cancer that we diagnose today. And the cure rate for that is about 99%. So overall, the cure rate for breast cancer is upwards of 90% and has only gotten better with each passing decade as a result of better early detection modalities, and also better treatment options, even for the most aggressive kinds of breast cancers.
Amy, I think you mentioned that you did not have a family history of this
No.
disease. Is the message then that every woman should be paying attention to this, doing their breast exams, getting those mammograms?
Absolutely, 100%. When I was actually resisting getting that mammogram, I walked into Robin Roberts' office, my coworker, my colleague, my friend, and also a breast cancer thriver. And I said, "Look, Robin, I don't have a connection to this disease. I don't think I'm the person who should be getting this mammogram. No one in my family has breast cancer." And she looked at me and she said, "Wow. Did you know that more than 80% of breast cancer patients have zero family history? You're exactly the woman who should be getting this mammogram because you don't think it can happen to you." And while she was like, "I'm sure you're fine," that is a myth that needs to be busted because we hear about if you're of average risk, you can wait until you're 50, you can get it every other year. But the truth is, what is average risk? If more than 80% of breast cancer patients have no family history, I would be so bold as to say there is no such thing as average risk. We're all at risk if we're women, if we're even men, and we're getting older. And that's what I've learned from this. That's my takeaway. And it's on us women to demand that we have access to the health care that we deserve and the tests that we deserve that could potentially save our lives.
Dr. Port, did COVID bring mammograms to a halt? Did people stop going in for screening?
It's a really good question, Jean. And absolutely a lot of routine medical care was put on hold for the time and spaces where it was felt to be the risk of exposure to healthcare facility or to being around other people or just traveling outweighed the benefit. We were really, I work at Mount Sinai, and here in New York City and at Mount Sinai, we were really at the very epicenter of the pandemic. And we did put routine screening mammograms on hold for about 2 months. That said, when we were one of the first groups to sort of get everything under control and to make our centers and our places safe again, keeping in mind that we were open the entire time for people who actually needed treatment. So women went into COVID receiving chemotherapy, and that didn't stop. And women who needed surgery for new diagnosis of breast cancer, and that didn't stop for those who needed it in the immediate future. But things like mammograms and putting those aside for a month or two really shouldn't change the prognosis overall. That said, we were also incredibly aggressive about getting people back in and saying, okay, you can put things on hold for a month or two or even three, but don't miss this year. And a lot of here in New York, a lot of people really relocated and kind of fled the city. And we've been really proactive about telling people, look, even if you have to go someplace closer to your new home, don't put your care on hold any longer. And these are not tests where you should just sit out for a year.
So we've talked a lot about diagnostic. Dr. Port, tell me about treatments. Is there promising new treatment on the horizon?
There sure is, Jean. Number one, as we already talked about, the survival rates for certain subtypes of breast cancer are already extraordinarily high, thanks to some of the incredible treatment developments and advancements that have come about over the last years. One thing that people don't realize is that between 2000 and 2010, that decade, the cure rate for breast cancer went up by almost 2% each year. So if you were diagnosed with breast cancer after 2010, you were 20% more likely to survive breast cancer than 10 years earlier. And part of that is related to, at that time, a new drug called Herceptin that targeted a very specific subtype of breast cancer, which previously had been thought of as quite aggressive and more difficult to treat with an ominous prognosis. And these drugs changed all that for that subtype of breast cancer. The thing that we're very excited about is the last kind of standing breast cancer that is more complicated and difficult to treat because we don't have as many targeted agents is a subtype called triple negative breast cancer. And we've made amazing strides in treating even that form of more aggressive breast cancer in the last few years. I would also say one of the things that people don't understand is that not only have we done really, really well with, what most people think is better treatment means more, new drugs, new therapies. One of the things we've also done really well with that I'm equally as proud of is figuring out who doesn't need some of these treatments unnecessarily. So, up until maybe 10 years ago, we were giving chemotherapy, for example, way more indiscriminately, not knowing as much about whether or not that person or their tumor type really responded to it. And we have much better ways of customizing and tailoring care today, no one size fits all, in terms of our approach to each individual. So sometimes better treatment is actually being able to dial down and still get the same excellent results. That's a huge win in my book, too.
Amy, you're in the information business, but is there a lot of disinformation floating around out there when it comes to breast cancer?
I absolutely think so. I think men think that they're immune to it. I think that certain women, and I was among this group, feel like if I'm healthy, if I exercise, if I take care of myself and I don't have family history, I'm not a candidate for breast cancer. I think a lot of people really feel like cancer can't happen to them. And so I have really made it a mission of mine over the last 7 years to tell women it can happen to you, it can happen to the ones you love. And the best thing we can do is put our health first. I think as women, especially, we tend to make sure our kids are taken care of, our husbands are taken care of. We take care of everyone around us, but we don't think about our own health and what would happen if something happened to us until it does. And so it is about prevention. I know that everywhere mammography has been introduced in the world, the breast cancer death rate has decreased. And so if we get our cancers, if we find our cancers early, then we have a better chance of surviving them. Bottom line, that's not a controversial statement. And I also think there are just a lot of women who, and I've heard this from them directly, and I'm sure Dr. Port has too, who don't want to know. They're afraid to find out. They're afraid to know what that lump is, or whether or not, their family history may repeat itself. And so they just say ignorance is bliss. But when it comes to cancer, we need to make sure women realize that more than any other real subject, knowledge is power. And the sooner you find your cancer, the better chance you have of surviving it, period. And so I just want women to know the power is in their hands to take control of their health and to be honest with themselves and make sure that they're not only making their appointments, but keeping their appointments and doing it, if not just for themselves, for the people who love them.
Amy Roback and Dr. Elisa Port, thank you both for joining us for this discussion today. Appreciate it.
Thank you so much.
And next up, we have a conversation from our underwriter, Bristol Myers Squibb. Please welcome Donna Cryer, the founder, president, and CEO of Global Liver Institute, and Catherine Owen, senior vice president of Global Development Operations and Global Drug Development at Bristol Myers Squibb.
Thank you very much. And I'm very, very pleased to be with you this afternoon. My name is Kate Owen, and I'm the Senior Vice President of Global Drug Development and Global Operations at BMS. As we're all aware, COVID-19 has really changed the way we think about things and highlighted to us health disparities around our country and around the globe. At BMS, we've long since been recognized for having an opportunity to take responsibility to help eliminate health inequities. That's why we've recently committed $300 million over the next 5 years to accelerate equity in diversity of patient populations and inclusive efforts in the United States. But that's a small fraction of what needs to be done, and we need to continue listening in order to be able to affect a change. We truly believe that by expanding clinical trial patient diversity, we will narrow the gaps of treatment and improve patient outcomes. Today, I'm really, really blessed to have Donna Cryer with me. She is the Chief Executive Officer of the Global Liver Institute. But more than that, she is a patient herself of inflammatory bowel disease and a 25-year survival of a liver transplant. She is a professional advocate, has a career in law, policy, consulting, public relations, clinical trial recruitment, and nonprofit management. I am incredibly pleased to have Donna join me just to have a conversation, and I would like to thank Donna for taking the opportunity and the invitation to join us. So for a very short period of time, we're never going to have enough time to discuss this properly. I'd like to welcome Donna to the foray and to all of you this afternoon. Thanks so much, Donna.
Thank you, Kate. It's an honor to be here.
It truly is. Actually, I'm incredibly impressed with your repertoire and what we're going to talk about. But the few minutes we have probably are never going to do it justice, and we're certainly not going to get to everything. But I would be very, very interested in your perspective on, let's look at this from a different level. We need systemic change. Systemic change requires a systemic response. And looking at it from your history, from your background, and what you've learned along the way, what would you say really would affect a real long-term change and ensure that clinical trials represents all members of the population wherever that is possible?
Kate, you're absolutely right that to have a systemic change, a systemic answer to this problem of diversity or lack of diversity in clinical trials and clinical research, it's going to take a systemic response. It's also going to take the entire ecosystem of stakeholders. It's not just researchers or clinicians. It's even not just patients and caregivers, but it's all of us together. And I would even like to, open that even wider to innovators from across spectrum, from device companies, from behavioral health models. It is really one of the proudest moments of my career to have launched the Liver Cancer Council at the Global Liver Institute to really bring a multitude of stakeholders together from diverse backgrounds to not just address one challenge, but really to address all of the challenges systemically to try to shift the outcomes, particularly for patients with liver cancer whose outcomes are so low, below 20%, about 18.4% overall. And but also maybe we can build a model that will work for other cancers. And we came to that model because of my background and sort of everything I've done since my transplant in law, but also working at public relations firms, working in advocacy organizations, working for payers, working for health systems, and working in clinical trial recruitment, and particularly working on solving challenges of diversity in recruitment. That really took creativity to solve. And we want to have that creativity, and that often comes from having different people in the room. And it's that creativity we hope to spark to solve this challenge.
And I think there is a level of creativity needed as you consider one of the major barriers for us is education and awareness and access. But if we get this right, what does the future of clinical trials look like from your perspective?
The future of clinical trials, and I think that future has come a lot more quickly during COVID. That may be the silver lining, because it has shown a very harsh spotlight on the sort of stacked layers of inequities that are responsible for ill health, and certainly that is true in cancer. But it also has highlighted um, different tools, whether that is, everything from e-consent, so very technical tools in clinical trials, to just the concept of bringing the trial to the patient. Bringing, whether it's the study medication or the nurse with to do the lab work into the patient's home. And so I think that the future of clinical trials looks a lot more like it does as we're starting to see clinical trials during COVID than it looks like the past of how we've had it concentrated around academic medical centers, with patients having to struggle through taking time off of work or getting someone to see the kids or taking two buses to a site. I think the future of clinical trials looks a lot more like now.
I think you're very, very right, Donna. And more importantly, I think we have to not only build the patient aspect into drug development, but also as you think about what a clinical trial does, it answers a scientific question and asks for scientific input along the way. But how we get that input, I think, should be more flexible. What we need is the same information and data, but how we acquire it should be more based on the patient and the caregiver's needs. I know that we could go on and on and on, and probably our few minutes didn't in any way do this topic justice. I know that we will continue to work together. Bristol Myers Squibb is incredibly committed to shaping the ecosystem of our healthcare providers and our clinical trial providers. And I welcome the opportunity maybe to have a longer time with you in the future. So thank you very much for joining me.
Thank you.
Donna and Catherine, thank you. We're now going to take a quick break. Feel free to get up, take a stretch, get a beverage. For those of you who are joining us on the Hop-In platform, you can use the icon on the left side of your screen to network with some of the other attendees here today. We encourage you to do that. And when we come back, we have a lot more content. We're going to be talking to the director of the National Cancer Institute, Ned Sharpless. We're also going to be talking to cancer survivor and actress Fran Drescher. So come back and join us in about 15 minutes. We will start up again at 2:10 Eastern. See you then. Welcome back, everyone. In this part of the program, we're going to look at the latest breakthroughs in science and the latest innovations in care. And later in the program, we're going to hear from cancer survivor and activist, actress Fran Drescher. Before we do that, I want to remind you about our polling feature where we have put up a new question. The question is this: what worries you the most about the state of cancer today? Again, if you've joined us on the Hop In platform, you will find this on the right-hand side of your screen. You can cast your vote there. And now for our next session, please welcome journalist Ray Suarez.
Thanks a lot, Jean. I'm joined by Dr. Ned Sharpless. He's director of the National Cancer Institute. He's held that position since 2017. Prior to his appointment, Dr. Sharpless served as the director of the Lineberger Comprehensive Cancer Center at the University of North Carolina. Dr. Sharpless, welcome.
Great to be here. Thank you for having me.
You know, there are a lot of institutions dedicated to cancer research, so people may not be familiar with the NCI. What is the role of the Institute in fighting cancer?
Sure. The National Cancer Institute is the the world's largest funder of cancer research. We provide both grants and other kinds of support for researchers to do cancer research, but also a lot of very critical infrastructure to cancer research, such as we run the National Clinical Trials Network and the Frederick National Lab, which does federally directed research, and have a number of other very important capabilities for advancing cancer science. So we really coordinate the nation's program in cancer research.
2021 marks the 50th anniversary of the National Cancer Act that established the National Cancer Institute. When President Nixon signed the act, he called it the beginning of a war on cancer. Has the act ended up being a significant step in the fight against cancer?
Yes, the National Cancer Act has been really important. It is, I think, when they thought about this back in 1971, they imagined cancer as being a much easier problem than it turned out to be. So it really required a mastery of human biology that we didn't understand back then. So, for example, they thought they were going to have cancer solved in, like 5 years. The idea was very quickly we would wrap this up. Cancer turned out to be a harder problem, but it did do some really important things. The National Cancer Act provided additional resources and funding for the NCI. It led to the creation of, some very important national infrastructure. It made the director of the National Cancer Institute a presidential appointee, which means that we have some better access to facilities within the administration. And it really, but probably most importantly, meant a lot for patients. So it brought this disease of cancer out of the shadows. It was a diagnosis that people didn't want to have. It was something one didn't talk about in polite conversation. And it really said cancer is a disease we can talk about nationally. And it led to the beginning of the advocacy movement in cancer, which has been critical to our progress. So the National Cancer Act was vitally important. And this is a really important anniversary to commemorate because we've made tremendous progress in the last 5 decades, but we still have a lot of progress yet to make, a lot of ways to go, because 600,000 Americans die from cancer in the United States every year. It's still the leading cause of death for Americans under the age of 65. So while the progress in the last 50 years has been extraordinary, we still have a long way to go.
You mentioned that early on, around the time of the signing of the act, there was an idea that this was going to be easier to solve than it's ended up being. Has this 50 years of struggle seen rapid, significant progress in some areas, in some types of disease, in survivability, in not only preserving life, but quality of life, that's been harder to achieve with other cancers? Have some turned out to be much more stubborn than others?
Yeah, that's exactly right. So I think back in 1971, they thought about cancer like you thought about tuberculosis. It was like a single disease entity where one sort of silver bullet therapy would wipe out cancer. And that was the hope and expectation. And that turned out to be untrue. What we've learned over the next 50 years, the last 50 years, has been that cancer isn't one disease or 10 diseases, but it's really hundreds or even thousands or even, now I think we think of every patient's cancer as being essentially distinct. They're all different from each other. And every subtype of cancer needs its own, sort of specialized targeted therapy. It has different epidemiology, different causes, different outcomes. So no longer, for example, do we talk about just breast cancer, one kind of cancer. of the breast. Now we realize that that's really many different diseases that respond differently to different kinds of treatment and different kinds of therapeutic approaches. So this, complexity, this going from a homogeneous entity to the very heterogeneous, complex situation we have today, has really allowed for great progress. Because once we started looking for silver bullets, we realized that we could make progress against each individual entity. And in some areas, we've seen a lot of success. Advanced melanoma, skin cancer, a common form of skin cancer, a highly lethal common form of skin cancer. When I started out in the field, was advanced melanoma was a terrible diagnosis. The majority of those patients really did very badly, and now we cure the majority of those patients using immuno-oncology and other approaches. So that's an area where there's been tremendous success. Also, in some forms of lung cancer, tremendous success. But then there are other kinds of cancers like brain cancer, pancreatic cancer, liver cancer, where the progress has been more difficult and it's been slower. And so I think one piece of good news is that the progress we made in few malignancies does give us hope that we can see this kind of progress for all cancers, for all patients with cancer.
When I had cancer surgery, among the sheaf of papers I was asked to sign, was a release that my surgeon was really pretty avid about, that I allow for genomic testing of the results of the surgery. How has genomics changed the field of cancer research?
Yeah, it's been a critical discovery. This is really the ability to take a tumor and get its DNA and its RNA out of it and sequence that completely, so-called genomic analysis of the tumors, has really led to this understanding. Before we were just looking under a microscope, and everything looked the same. But then when we actually molecularly interrogated the cancers, we realized that there was a lot of variability, a lot of variety of cancers there, and that's what's made possible this precision oncology movement that allows us to treat each patient differently. So, we have some drugs now that work for 1 in 1,000 patients. But if you are one of those patients and you have the right kind of cancer based on molecular subtyping, the responses can be marvelous if you're that patient. And so that's the story over and over again, is for each kind of cancer, genomic analysis and other molecular approaches have allowed us to really treat each individual tumor as its own special problem, and thereby make progress, much better progress for most patients. And not for every patient, as mentioned, but in aggregate, cancer mortality is considerably down since the 1990s. It declines every year, or at least since the 1990s has, for a variety of reasons. And a lot of this is new therapies.
One of the areas where there's been tremendous progress is in diagnostics. But that also gives us the challenge of trying to figure out who's going to die from cancer as opposed to who's going to die with cancer. Have we had to dial in just when chemotherapy and surgery is the really proper response, as opposed to those cases where we know something we wouldn't have known before, but a cancer may be so slow moving or not life threatening that maybe significant measures are not required?
Yeah, this is the problem of overdiagnosis and overtreatment. As you alluded to, our tests in some cases are so good, they're so sensitive, that we can now find certain kinds of cancer at very, very early stage when the tumors are what the oncologists call indolent, meaning that they are very slow growing, they're non aggressive. And these are tumors that you can die with, but not of, in many instances. And so, for example, the classic is prostate cancer in older men. This is a tumor that, prostate cancer is a really important cancer. It is an important cause of mortality of men in the United States. But some patients with prostate cancer have very indolent disease. And in those patients, sometimes aggressive treatment is worse than the actual disease. And so trying to understand who's got these kinds of aggressive cancers that need surgery and radiation and chemotherapy and other measures right now versus who's have kinds of cancers that may need less aggressive therapy or even no therapy. Now we in the United States employ watchful waiting, meaning we just observe some patients with cancer. So telling those patients apart is hard, but again, it comes back to this molecular diagnosis. One of the tools that we really use to tell are the sort of clinical features of the tumor and the patient, but also the molecular details of their tumor. That allows us to predict which tumors are more indolent and which are more aggressive, and thereby tailor therapy to each patient appropriately. This has been a really important movement. In breast cancer, we have really learned how to dial back in some of the patients and give them much less aggressive therapy, no longer having necessarily to give cytotoxic therapy that makes patients lose their hair and have all those quality of life issues. And so without compromising the survival outcomes for those patients. So that's really meaningful for patients. If we can de-escalate therapy and have equivalently good good outcomes, that's a win for patients.
Having said that, what are the fastest growing cancers in the United States? And are there approaches we can take to prevent or limit them?
Right. So by fastest growing, we mean increasing in incidence and mortality, not most rapidly growing tumor. Yes.
Right.
In general, most cancers in the United States are declining in mortality. I mentioned lung cancer and melanoma, breast cancer, colon cancer, prostate cancer. These are things that have been declining in mortality in most cases, for more than a decade. But there are a few cancers that are not declining in mortality, that are even increasing mortality. Many of those cancers are associated with obesity. The national obesity epidemic has also been an important cause of cancer. So cancers like endometrial cancer, cancers of the uterus, as well as liver cancer can be associated with obesity, and the incidence of those tumors is going up. We're seeing some cancers where the change in incidence isn't dramatic. It's more or less flat. It's not going down. It's not going up. But we really haven't made much progress in mortality. So these are cancers like brain cancer, glioma, and pancreas cancer. And in those kinds of cancers, the mortality benefit that we've seen in other areas has not really been apparent in those tumors. So obesity-associated tumors, and then tumors that have just where we haven't made much progress, are the areas that really concern the NCI now. There are certainly things we can do to try and reduce the incidence of cancer. We talked a little bit about screening, the idea of detecting cancers, and there are certain malignancies like cervical cancer, colon cancer, breast cancer, where screening is quite useful. Combating obesity is an important way to reduce cancer incidence. Getting rid of mutagens, of things that damage DNA, the most important is tobacco smoke. So not exposing yourself to carcinogens like tobacco smoke is a way to reduce cancer incidence. The NCI has a lively portfolio of research on these areas of how to combat obesity, how to adopt proper tobacco control, how to increase uptake for screening. These are all measures that we think could have a very significant impact on cancer incidence and outcome as they become more broadly adopted.
Given everything you've said about these different areas, how do you set priorities, and how do you set funding guidelines? How do you prioritize when there are so many different kinds of cancers? Some have had results that are more promising than others. There's ethics, there's efficacy, there's efficiency in a limited pool of cash. How do you make those decisions?
Sure. Well, one piece of good news here has that for the last few years, there's been very good bipartisan support in Congress for cancer research. So we have benefited from strong increases to the NCI's budget. There's been good support for biomedical research in general, but I think particularly strong support for cancer research because that there's so much enthusiasm and excitement about cancer research now, and there's such clear evidence of progress that I think legislators feel like this is a good use of federal funds. And so we have been in the good position of having more and more money to spend on these refractory and challenging problems, like we discussed. I think, how to prioritize. One thing that's important to realize is that in some way, understanding the basic biology of cancer is a good investment for all kinds of cancers. So we have these scientists working in labs trying to understand, what kind of makes cells tick. And they will make discoveries without any particular cancer in mind. They won't say to you, I'm working on colon cancer or breast cancer. They'll just say, I'm working on basic biology. But often those are the discoveries that really change the needle, that can really have very, very meaningful, that really move the needle, that can have very meaningful outcomes for patients. And so we always want to support those kinds of basic biologic discovery, investigations that lead to these transformational discoveries. We also want to provide the critical infrastructure that allows all kinds of cancer research to go forward. Things like a clinical trials network. So that same network can then be used to do studies in breast cancer or pediatric cancer or any type of cancer. So we try and support things that don't force us to pick winners and losers. But lastly, I as a practicing medical oncologist, am very much sensitive to the issue that there are areas where we haven't had enough progress, and I always want to ask the NCI, are we doing enough for these most challenging problems? Are we really making the progress we need to see in those tumors where the progress hasn't been as good? So it's really a combination of supporting all cancer research and then finding the scientific opportunities that really allow us to target for progress in specific areas when they become apparent.
I want to spend these last couple of minutes talking about the effect of the coronavirus pandemic. I've been reading that a lot of people are skipping or missing or postponing diagnostic tests and screenings, that treatments have been delayed. Uh, is this a real threat as we assess the broader health impacts of one specific disease?
Yeah, this is a very serious problem that the NCI is spending a lot of our time on these days, and working with our partners at academic medical centers and healthcare organizations throughout the country. Um, when the pandemic started, there was a significant concern and fear about the ability to provide care for patients safely in a way that protected the patients and the caregivers from infection. And then also, I think many hospitals and clinics closed to cancer patients because of a need to preserve hospital capacity. So they wanted to make sure they had enough ICU beds for coronavirus patients should they come in. And those things were reasonable and I think wise at the time. But what that had the unintended effect of doing was it delayed cancer diagnosis for lots of reasons. So patients stopped getting screened. So mammography clinics and colonoscopy clinics and things like that really stopped seeing patients for a while. And then often patients are getting evaluated for a symptom. That's actually the most common way people are diagnosed with cancers, when they present to a doctor with some new symptom. And patients were not going to doctors. They were scared to come in for their new cough or maybe a lump or something that normally would be considered a serious symptom of cancer. But they were not ignoring these symptoms, but not having them evaluated in a timely fashion. So this led, decreased screening and decreased evaluation of new symptoms led to delayed diagnoses, and this has been very shocking. So we and others have seen national data that the new cancer diagnoses for a few months of the pandemic may have declined in the United States by more than 50%. And there's no reason to believe the true incidence of cancer during that period declined by 50%. That was just the diagnosis of new cancer was decreased by 50%. So we believe in many cases those tumors are just going to become apparent later at later stage, and that means that they will be harder to treat. They will have a worse prognosis. We did some modeling of this phenomena of delayed care and decreased care and delayed diagnosis, and estimated for breast and colon cancer alone, we expect to see on the order of 10,000 excess deaths over the next decade. There is no reason to believe that modeling exercise wouldn't also, that lung cancer and pancreatic cancer and other kinds of cancer wouldn't similarly be affected. So we think there will be excess mortality coming in future years from delayed diagnosis and delayed treatment now. And this has also, by the way, been supported by more and more data from other sources, from electronic health record data and national laboratory data, and other countries have seen similar findings. The UK has provided similar data to ours. So this is going to happen. The impact on patients is very significant. And now we really are talking about what we can do about it. Can we encourage catch-up screening? Can we have patients try and come in and get that missed mammography late done, or colonoscopy? Can we encourage hospitals and clinics to try to reopen and see patients in a safe way that is both good for the cancer patients in terms of getting them their treatments or their evaluation, but also protects the caregivers and the patients? And and that in particular has been a problem of creating sort of national best practices. What surgery can you postpone? What surgery has to happen now? What kind of care is elective and not as urgent versus other kinds of care that can't be deferred? So the good news is the American healthcare system is quite ingenious, and doctors and the medical societies have started to recommend best practices in this regard, and the NCI is definitely researching these opportunities. And I think with collective action, we can all agree that we need to prioritize the care of our cancer patients now. And I think now, far enough in the pandemic, we can do both. We can take great care of our patients, but we can also do it safely.
Dr. Sharpless, thanks a lot for your time.
Thank you for having me. Great speaking today, Ray.
Ned Sharpless is director of the National Cancer Institute. And now I want to turn the program over to my old colleague and friend, John Donovan.
Thank you, my friend, Ray Suarez. And we're now going to actually continue the conversation that you started, Ray, on this issue of where the field is, and particularly try to look at some of the more specific technologies that are being developed, but also have an overview of where things might go. And I want to welcome into the conversation for that purpose, first, Rachel McGuire, who is a research director at I'm reading the wrong names. I'm going to say Lisa Butterfield, who is Vice President of Research and Development at the Parker Institute for Cancer Immunotherapy, Otis Brawley, who is the Bloomberg Distinguished Parker Professor of Oncology and Epidemiology at Johns Hopkins, and Catherine Marinac, who is a member of the Faculty of Medicine at Dana-Farber Cancer Institute. And Dr. Brawley, I want to start with you. My wife, who's a physician, I mentioned to her that we would be having this conversation, and she said, please don't use the word breakthroughs. Breakthrough is not a word that applies when it comes to cancer. It's not how it works. And I want to check in with you on that and see if there's something for us lay people to learn from that lament on her part, that the news media, et cetera, tends to be looking for breakthroughs all the time, and that maybe that's not the way we should be thinking about it?
Well, first, I wouldn't blame it on the news media. I hear it in medicine as well. But I agree with your wife. We need to be thinking about the fact that we're making small incremental progress. Now, over time, that small incremental progress can add up to a lot, but it is rare. Maybe in the last 50 years, once or twice, I can think of a drug or a treatment as being a breakthrough, but there's a tremendous advances. You know, our death rate from cancer has gone down 30% since 1991. So we are making progress, but breakthrough is a bad word.
So if we look at this from 30,000 feet, sort of the speed of at which we are learning things about cancer, I'll put it this way. Do we know a lot more about cancer than we knew that this time last year? Are things moving that quickly?
I think the answer to that is absolutely yes. The last 50 years of the war on cancer, which was signed by Richard Nixon, we've learned a great deal more. First, about genetics. We learned that cancer was a genetic disease. Then we started learning what's going on in the cell. And indeed, we've even redefined what cancer is. Cancer in 2020 is really a different definition from cancer in 1975. And as we've learned these things, our approaches toward treatment, the immunotherapy, as well as targeted therapies. And I'm really excited about the fact that we've learned a lot about what causes cancer so we can actually apply prevention. And much of the great hope for the future actually comes from prevention of cancer.
We used to have the image again of the lone researcher late at night with the white lab and the Bunsen burner going, making a dramatic discovery. You've already said that's not how things work, but where I'm getting at this question is just how interdisciplinary is the study of cancer? How many different kinds of specialties need to be involved, are involved, and how important is coordination and cross-pollination among those different groups of researchers?
Well, just on this panel, you have immunologist, molecular biologist, an epidemiologist who does the counting. It's really a diverse group of scientists. And then when we start applying the treatment, it's very important to applying it is nursing research, other social workers, even economists, because one of the things that we've actually calculated is we could decrease our cancer death rate in the United States now by 20% if everybody in the country just got all the knowledge that we know about cancer prevention, screening, diagnosis, and treatment right now.
So what's the obstacle to that happening?
Lots of social issues. Believe it or not, one of the biggest obstacles to a lot of people getting good treatment is lack of transportation. Another issue is affordability. We're now starting to see differences in the differences in the mortality from cancer in southern states that have not expanded the Affordable Care Act versus Northeastern states that have. I mean, literally, the death rate from breast cancer, for example, in Massachusetts, is almost half what the death rate is in Mississippi.
So interesting. You're saying there are a lot of low tech issues involved. Our brief in this conversation is to turn to the technology, so I'll do that now. As you pointed out, we have people who are very, very involved in again, I don't want to use cliches like cutting edge, but let's just say darn fascinating areas of expertise. And one of them is, you mentioned it, immunotherapy, and I want to bring in Dr. Butterfield. Welcome, Dr. Butterfield. Tell us what is immunotherapy and what is going on with cancer and research in your field.
It's Thank you for including me. It's hard not to use the term breakthrough, I confess, when thinking about immunotherapy. We're targeting the cancer as though we would target it as an infection. We're instructing the immune system what to look for, and then we're letting the immune system go and find it and destroy it, and then remember it afterwards. So it's a very exciting time to see immunotherapy finally incorporated into our armamentarium, and to see some of these recent successes from all the technological advances and all the basic and applied research.
So, Dr. Butterfield, what was the thinking that got people moving in that direction? In other words, you drawn an analogy, I suppose, to vaccines, for example. Did it come out of that field, that sort of thinking? Is this an idea that's been around for 50 years and we couldn't do technologically, or is it a relative?
No. Sorry, one of the observations was around spontaneous regression in skin cancers, where someone had a tumor and then the tumor goes away, and what's left are T cells or immune cells in that site who seem to have cleaned up everything that was a tumor. And we didn't know what to think about that. We didn't know how to instruct the immune system. So it took decades of technological advances. And we're at a point now where we can sample the tumor. We can profile all the genes, we can profile dozens of proteins, we can look at the environment that the tumor cells are in and better understand it, and then design therapies around that.
And is this this sort of critical mass that you're talking about, is this very, very recent, or has it been a slow accretion of knowledge? In other words, did this thing suddenly really break open? Okay, I'm using half the word breakthrough. Break open in the last, say, 5 years?
I guess when I first got involved about 25 years ago, it actually was considered voodoo by some of my colleagues, and we had, it was more of a belief system that this could work. We really believed that it made sense, and so it should work. And it really took progress in mouse models, progress in technologies, and then roughly 10 years ago, we finally had a drug that made a difference, and it didn't make 10 more weeks of life difference with a lot of toxicity. It made durable years difference for people. We saw what we call the tail on the curve of survival. We saw a lot of patients' tumors come back, but then a proportion of the patients went out years and their tumor never came back. And that finally gave us real life patient data in which we could study and then build on. And so we've been building on that for the last 10 years with novel combinations and increasingly impressive technologies to better understand it and iterate in a stepwise fashion.
As we've heard repeatedly in these sessions this afternoon, there are many, many, many different kinds of cancers, potentially hundreds of different kinds. Are we looking at a world where immunotherapy potentially, eventually, will be able to address all of them?
I think so. I think that we have different tumors, different tumor types. They all have a different biology, but some are heavily mutated because of sun exposure or because of carcinogen exposure. And those have been some of the first to show great response to immunotherapy. But we have others like pancreatic cancer, prostate cancer, and brain tumors where they've remained resistant, but then we study that biology and then we start to add rational combinations. We take this pharma drug, we collaborate with that biotech, and then we bring that expertise together and try something new. And I think eventually we're going to, I think it'll be personalized. I think we'll take that specimen of tumor, profile it, see what's right and what's wrong, and then have an armamentarium of immune acting agents that we can apply to that.
You really are, do sound optimistic. You're
I
one of the
do.
more positive voices. Yeah. Yeah. All right. That's terrific. Dr. Marinak, you're doing something fascinating term to me, liquid biopsies. I'm going to just let you talk. Tell us what that term means and tell us where you're going with that.
Yeah, thanks so much for having me. So liquid biopsy is a fairly broad term, but it's really defined as a collection of bodily fluid, most often a blood sample that we can analyze to give information about a cancer that may be present. Like I said, we most often use the blood because the blood actually is a very rich source of information about cancers in the body because tumors shed a lot of information into the bloodstream. They shed cells, circulating tumor DNA, as well as other molecules, which we can collect and analyze in something as simple as a blood sample. There's a lot of work in this area of liquid biopsies, and it's being applied right now to the diagnosis and management of patients with cancer, to their treatment. One area that I have been particularly focused in is understanding how we can leverage this technology of liquid biopsies to better detect cancers early, particularly screen for cancers that we don't currently screen for that are diagnosed too late, like pancreatic cancer, which was mentioned at the beginning of this session. And we know that an important way to reduce overall mortality from cancer is to diagnose it as early as possible when treatment is more likely to be effective. But there's a large proportion of cancers that we're not able to detect early and are diagnosed too late in their disease course. And the hope is that this liquid biopsy technology can help us diagnose lethal cancers earlier. And in fact, there are several different tests that are already quite far along in development that are intended to be used to screen patients for multiple cancer types simultaneously using something as simple as a blood test in patients that have no symptoms. And these tests have already been validated, meaning that in very controlled settings, they appear to do a really good job of detecting a wide variety of different cancer types, including ones that we don't currently screen for. And what's particularly exciting to me is that these tests actually do a really good job at picking up aggressive cancers. So cancers that are more likely to cause harm, which I think is valuable because it minimizes some of the concerns that Dr. Sharpless and others have talked about, such as the risk of overdiagnosing cancers that are unlikely to cause harm.
So you just answered the question I was going to ask you next about the potential philosophical, ethical, and practical challenges of having the availability of a test that could find a bunch of stuff and maybe panicking people. So you've addressed that. But I also just want to get a sense of how you would see in 20 years from now, say your work has reached fruition, where there's a whole bunch of things that we could test for. How do you see its application? Do you see, you're drawing for a blood panel on 50 cancers on your annual or whatever frequency of checkup you do? Is that how you would see its application working, or would you see somebody tested on? Yeah, go ahead.
Yeah, I mean, we're a long way off. I think the optimistic vision is that a cancer screening panel could be added in the primary care setting to regular blood testing that's done. I think more realistic in the near term, a test like this would be used to complement our existing screening paradigms. We already know that mammography is effective in diagnosing breast cancers early, and colonoscopy is effective. So potentially this offers an opportunity to detect cancers that we're not currently looking for, we don't have a means to search for, and do so earlier. I think that there's a long way to go with respect to understanding the risks and benefits of this technology, how it's used in the clinical setting, whether it's going to be used in the primary care setting, how the technology performs in diverse patient populations. Still a lot of questions before an individual can go to their doctor and get a blood test. It's not currently available, but we're definitely making a lot of headway, and it's a very exciting area of research.
Dr. Brawley, you mentioned when we were chatting a few minutes ago, you were talking about the disparities, Massachusetts versus some states in the South, access to healthcare, insurance, transportation as being drivers of these disparities. I'm wondering if in any way the technological possibilities that are being discussed here and others have a role to play in not zeroing out these disparities, but in narrowing them. Are they relevant to this issue, or are the issues you're talking about all pretty much socially driven?
Well, potentially a blood test could be done much easier in terms of the logistics, and it might actually even be cheaper than some of the testing that we do now, like spiral CT for the detection of lung cancer. So some of these new technologies actually might lower the disparities that I'm talking about. However, it is true that when we learned how to screen and treat for colorectal cancer, that's when we started getting disparities in colorectal cancer mortality. The poor doing worse than the non-poor middle class. Same for breast cancer. Whenever we introduce a new technology, we usually do initially cause some disparities. The one exception to that, by the way, is prevention. There are no disparities in smallpox, for example. It's something we have a great preventative for, and there's no rich poor disparity, no geographic disparity.
But if there's a challenge just getting diagnosis, if there's a disparity in access to diagnosis, it sounds as though, for example, a liquid biopsy could really bridge that chasm.
I'm hoping things like the liquid biopsy do bridge that chasm. I'm hoping that very simple, straightforward treatments, and I'm hoping immunotherapy becomes a very simple, straightforward treatment in the future, and that might actually improve outcomes as well.
I just want to ask, in the minutes we have left, our two frontline researchers doing such exciting things in your fields. And I'll start with you, Dr. Butterfield. What do you look at what other field of research in cancer treatment and understanding that's not your field are you excited about?
I'm pretty excited about molecular biology right now and the ability of us to create new molecules. We can do that in ways that we couldn't before, and we can rationally design things we can rationally design structures that will change the specificity of immune cells. So the ability to create new structures, to insert them via CRISPR, for example, into immune cells, and then deliver those immune cells. That's the marriage of cutting edge molecular biology with immunology that's really expanding our capabilities to treat novel settings, and so that's what I'm excited about.
All right, Dr. Marinak, how about you?
Yeah, I think, just expanding on the use of the liquid biopsy technology in an area that I don't work on, but I think is really exciting and relevant to some of the information that's been presented by Dr. Butterfield and others, is just the use of liquid biopsies as a minimally invasive tool to detect cancers that are already present. So potentially, that are used as a strategy to do a biopsy when a tissue biopsy is hard to reach or inaccessible. We know that the biopsies are very important in directing treatment decisions. It's also an exciting opportunity to think about understanding how a patient's responding to different therapies. We can't do tissue biopsies serially during treatment, but a liquid biopsy offers an opportunity to understand exactly how a tumor is responding to treatment and may inform future decisions for a patient's care. So I think that's a really fascinating area of research.
All right. Well, Dr. Marinak and Dr. Brawley and Dr. Butterfield, you did give us some hope. So it's nice to leave things on a positive note that the future is going to look better, something we really want to hear these days. So thank you for that. Thanks to all three of you for joining us. Now I want to welcome for a session our underwriter, Amgen Oncology. Please welcome Rachel McGuire, who is research director at Institute for the Future, PK Morrow, who is vice president of global development and therapeutic area head of hematology for Amgen, and Lisa Kennedy Sheldon, who is clinical and scientific affairs liaison at Oncology Nursing Society.
Hi, everyone. I'm Lisa Kennedy Sheldon, and I'm thrilled to be moderating a conversation between Rachel McGuire, who heads the Health Futures Lab at the Institute for the Future, and Dr. PK Morrow, the Vice President for Clinical Development from Amgen. Welcome, Rachel and PK.
Thanks, Lisa. Very happy to be here with you.
Thank you so much, Lisa. I am thrilled to be here and to be engaging in this conversation about cancer care.
Wonderful. Glad to have you here. PK, would you like to talk about some of the impact of COVID-19 for people with cancer?
Absolutely. Cancer itself is already so difficult and challenging a diagnosis and disease to deal with. But you layer upon that the fact that patients who are now being diagnosed with cancer are having to deal with isolation in terms of receiving that diagnosis alone, as well as the stress and anxiety that when they do begin treatment and continue with treatment, they may not be able to have the family support that they typically would have. The positive, I think, in all of this is that with this urgent situation, I think all of us have been united in the desire to make life better for patients who are dealing with such a difficult disease. And that's through telemedicine. In other words, bringing the healthcare provider to the patient.
But we really have seen changes in practice that may have long-term implications for access for patients. And maybe you could address some of these, Rachel. What are some of the things coming out of the pandemic, those changes in care that may last into the future and change the healthcare delivery system?
Thanks, Lisa. PK started to talk about telehealth and what that's afforded for both providers as well as patients and families in terms of improving their care, or at least mitigating the risks that they perceive or are real around face-to-face care in the midst of COVID. And I think anyone who's been watching healthcare for a long time, like I know you have, Lisa, and you, PK, knows that no one ever anticipated the rate at which telehealth visits would grow, telemedicine as a field would really take off. I mean, a lot of people have been waiting for this for a long time, and within months, we saw utilization rates that we anticipated would take more than a decade to see. Then we have to start understanding what quality telehealth looks like and where it's the best medium for reaching people and where there are others, perhaps face-to-face, that we shouldn't get rid of just because we have this new digital infrastructure in place.
Rachel, that's a great point. And I think some of the changes we've seen in reaching patients with virtual methodologies is certainly in clinical trials. PK, could you talk a bit about how clinical trials have been able to continue and reach patients during the pandemic?
When we look at clinical trials and how COVID-19 has affected them, we've really compressed the innovations that are required for clinical trials in a very short time because of the fact that there's an urgency there in order to continue to accelerate innovation for patients. And so we are enabling them to receive the drug directly in their homes for self-administration or administration by a healthcare provider or caregiver. What we've done at Amgen is to ensure that there's an element of what we call hypercare. We really ensure that there's an intensive period in which the patient and the healthcare provider are having that support in order to enable telemedicine to be appropriate and also successful within the setting of a clinical trial.
I do want to just continue a little more with telehealth. What is this going to mean for the future after the public health emergency? And Rachel, I'm going to direct that question to you.
Sure. It's an exciting time for qualitative researchers to dig deep into what are the core differences when care is delivered virtually and when care is delivered face-to-face. And clearly the technology will get better and better. so that you could argue that we'll increasingly be able to replicate certain parts of what a face-to-face visit looks and feels like today in a virtual setting. That said, combating social isolation is critical to good health. And while many people are lucky to have a caregiver in the home, many people don't. And for those people, that face-to-face visit that takes place in a clinical setting, that can be some of the only time that they're able to speak honestly and openly about their difficult health status. You could certainly see the pendulum swing too far to telehealth and us lose all the benefits that come from that face-to-face interaction.
I heard someone use the phrase webside manner instead of bedside manner, and that most, physicians are not taught how to interact or do a thorough assessment, in a Zoom call, right?
One of the questions people are asking right now is what will sustain from how things have changed during this moment of crisis. So if we're going to take this seriously and really think about addressing more of our care services in virtual settings, then we have to start as an industry to recognize that things like broadband are now a core health resource.
So we have to think about that infrastructure before we move forward and say, telehealth and telemonitoring are going to be the solution. I would be remiss not to ask about what these changes that have happened currently because of the pandemic and what's going to accelerate our change in delivery models for the next normal.
My hope and my dream is that this COVID-19 pandemic has been an opportunity for us to narrow our focus even more towards the patient and become even more patient-focused. I think that if we continue to keep our North Star in terms of patient innovation and true patient care, I see technology supporting this and also our partnership with patients in supporting that innovation and that approach.
Well, thank you. I think that's a great note to leave our conversation on today. I want to extend my thanks to Rachel McGuire and PK Morrow.
Thank you, Lisa.
Thank you, Lisa.
Thank you, everybody. And Lisa, website manner. I haven't heard that one before, but I like it. I'm going to use it. Our next conversation is going to focus on colorectal cancer. So I want to let you know if you have a question on that particular topic. Again, we would love to have you join the conversation. Just use the chat box below to put in a question, and it has better chances of getting into the conversation if it's short and on point and not repetitive to something that we've already said already. But I want to welcome into this conversation three specialists, three experts. Dr. Darrell Gray, who is gastroenterologist and deputy director of the Center for Cancer Health Equity at The Ohio State University. Sung Pobletti, who is the CEO of Stand Up to Cancer, and Paul Limburg, chief medical officer for Screening Exact Sciences. And Dr. Limburg, I want to start with you. Colorectal cancer is one of the ones that seems to be on the increase. And if I'm incorrect about that, correct me. No, you're nodding. Okay, so that's why we're putting a special focus on it. Do we have any idea what's going on and why? And particularly the trend towards younger and younger people being diagnosed with colorectal cancer?
Yeah, John, thanks for hosting this important conversation. It's a privilege to be here with my other distinguished panel members. I think overall, colorectal cancer incidence mortality rates have shown some positive trends in recent years. But as you pointed out, there are some less favorable, more alarming trends in younger patient populations. So particularly in individuals younger than age 50 years, we are seeing growing numbers of cases presenting at more advanced stages of disease, translating into reduced survival for patients who are diagnosed in that pre-50 age range. We don't fully understand all of the factors that are underlying these trends. We do know that screening is effective. Earlier detection of cancers lead to more curable interventions, or curative intent interventions. And unlike some cancers, colorectal cancer can actually be prevented by detecting and removing the precancerous polyps.
Is that prevention is that kind of 100%? If you catch it early enough, it's extremely high likelihood that you'll be cured of it?
if you can find the precancerous lesions and remove them, they should be gone. They don't result in an invasive cancer. Now, patients who've had precancerous polyps are more likely to develop additional precancerous polyps. So we would keep a closer eye on such patients compared to the general population who wouldn't have polyps, for example.
What is now the age group of which, or the age cohort who is recommended to begin getting screened for colorectal cancer, and has that changed?
Traditionally, we used to suggest that colorectal cancer screening start for average risk individuals, meaning those whose only known risk factor is age. We would initiate the screening process at 50 years. More recently, based on the trends that we just discussed briefly, that age of initiation is being lowered to 45 years. The American Cancer Society came out in 2018 with that as a qualified recommendation. More recently, the United States Preventive Services Task Force just issued draft recommendations within the last several weeks, also supporting age of initiation at age 45 years. Now, that's for general population screening. For some population groups, such as African Americans, recommendation to start screening at a younger age has been present even back over several years, but again, starting at age 45.
Okay, you brought up the topic of African American susceptibility to this disease, which is where I wanted to turn next, because it's another community that's being disproportionately affected by cancer, um, like so many others, in fact. And I want to turn to Dr. Gray. Do we have understanding? Is that basically social determinants being involved in the 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 disproportionate number of African Americans who are experiencing colorectal cancer?
John, thank you so much for bringing that to our attention. As was mentioned earlier by Dr. Brawley, certainly social determinants of health play a role. And when we talk about social determinants of health, just to put it into context for the viewers, we're talking about those factors in which people live, work, play, pray, and age, and really the larger social structures and power inequities that contribute to those things. So as you mentioned, African Americans do have a high incidence. As a matter of fact, the highest incidence and death rate from colorectal cancer as compared to other racial ethnic groups. And it's not just biology. It is not just being Black or skin color that has to do with that. It's these other factors, social determinants of health. Inequities in access to high quality care, income inequality. Transportation was mentioned by Dr. Brawley as well, or access to transportation. Historical factors that impact policies such as redlining or housing segregation, how that impacts downstream to manifest as poor health outcomes such as cancer. And certainly we've seen that as well during this COVID-19 crisis. So yes, to answer your question directly, John, social determinants of health do play a role.
And is there anything being done right now to address that disparity?
Yes, certainly there are centers, and I'm proud to be at one here at The Ohio State University in our Comprehensive Cancer Center, our Wexner Medical Center, where we're doing different things to address social determinants of health, because we understand that we cannot wait for people to come into our clinics. We cannot wait for people to come into our hospitals. We have to step outside of our white coats and get proximal to those who are experiencing these inequities. And so we have several programs in place to address the housing insecurity, to address preventive care and preventive measures, particularly health behaviors. We have research programs that are doing the like. One example is we're partnering with the National African American Male Wellness Agency on a program that we affectionately call Black Impact 100, which is navigating African American men beyond barriers to care, certainly screening, such as colorectal cancer screening being one of them, to ultimately have healthier lives and live longer.
It's called Black Impact 100, did you say?
Yes, that's one of a current research study. We're now in the final weeks of the intervention phase of this research study that was funded by OSU through a Connect and Collaborate grant mechanism.
What does the 100s refer to? I'm just curious.
100 Black men. So this is our first pilot where we're doing a community-based intervention. So we have a community partner who's been involved in the design of the study and implementation of the study. And what we're doing is we have several aims. One is we want to impact people's numbers. So when we talk about numbers, and that's what we say kind of in lay fashion, to talk about those factors that increase your risk for cardiovascular disease and cancer. We're also navigating people to getting primary care and ultimately to screening, and certainly to a point in a discussion earlier during this summit. We're trying to ensure that African Americans are aware of clinical trials and are engaging in them. So we have several pillars to this study, and we're looking forward to wrapping this up and ultimately disseminating this knowledge from this study to the public in the coming months.
Thanks very much. And speaking of alliances and partnerships, Dr. Pobletti, first of all, thank you for your patience and my only getting you into the conversation now. But you have recently joined forces with Dr. Lindberg on an initiative that aims to address the challenge of colorectal cancer in underserved communities and communities of color. Can you tell me about that?
Absolutely. And I just want to reiterate some of the discussion that's already happened. We know that colorectal cancer is treatable and survivable if caught early, and screening is really a key factor in reducing colorectal cancer deaths. But if you take a look at the statistics, colorectal cancer is still the second most common cause of death. And about 1 in 3 adults over 50 don't get the recommended testing. And you've also heard from Daryl that in the African American communities, they have the highest rates of colorectal cancer. Black Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. And the impact of COVID-19, especially during the stay-at-home orders, it's really been devastating. And I want to quote one of our scientific advisory committee members, Dr. John Carpton, who recently said, "It is no longer acceptable just to be woke, and we must take action against health inequities." And this is why I'm really thrilled to announce that Stand Up to Cancer has received a $10 million grant from Exact Sciences to propel a movement toward making America a colorectal cancer-free zone. And these funds from Exact Sciences, it will support an outstanding team of scientists and clinicians and advocates who will collaborate to share best practices and help individuals make informed choices to get colorectal cancer screening in underserved communities. A significant portion of this grant funding will pay for the screening tests and follow-up colonoscopies for the underserved community. And I really want to make very clear that it's about informed decisions and informed choice. During the pandemic, when there are so many individuals scared to go outside to hospitals and other institutions, there is a available screening methodology that can be done at the comfort of patients' homes. And we have to make certain that we educate, bring awareness, and make certain there's a call to action that's critical to this movement of getting everyone screened.
Dr. Pobletti, did you say you want to make the United States a colon cancer-free zone, the whole country?
Yes, indeed.
So that's a cancer-free country, not just a zone.
Yes.
Is that? I mean, do you see that as what's the word I'm looking for? Probable, plausible?
Yes, and let me tell you why. This is something that's even bigger than Stand Up to Cancer and Exact Sciences. We need other collaborators like insurers, advocacy groups, community leaders, and the National Cancer Institute. Dr. Ned Sharpless, if you are listening, we need you to support this initiative, because united, we can have a country where people aren't dying unnecessarily from a disease that's treatable and survivable if it's caught early.
Dr. Lindberg, I want to put this question as delicately as I can, but the ways to screen for colon cancer involve, part of the body people don't want to think about, talk about, including the at-home tests. How do you, I don't know if stigma is quite the right word, but there's a barrier there, a psychological barrier to people wanting to deal with it. How do you get past that?
Yeah, thanks, John. If I could just emphasize a couple of the key points that Dr. Pobletti made. We recognize that there were a number of people who, even prior to the COVID pandemic, weren't taking advantage of colorectal cancer screening. So about a third of the population was not up to date, even prior to 2020. With the decrease in healthcare visits and the fear, the anxiety, the constraints on access that we've all been facing during this current challenge, those numbers continue to decline. And we're seeing that, screening visits may be even 30%, 60% lower than that baseline. So we need to do something now. For colorectal cancer, we do have multiple available, effective, accessible options. Dr. Palmetti mentioned that there are home-based tests, stool-based tests. Like you alluded to, that's probably not top of list for anybody in terms of their favorite things to talk about or think about. But what we need to recognize is that these tests are effective. These tests can be conducted and completed right in the privacy of a patient's home. For a test like Cologuard, there's also navigation support to help walk through every step of the process and allow patients to return their sample without ever having to leave their home. So it is not acceptable for us to do nothing. As Dr. Gray mentioned, we need to not accept the status quo. If we take our focus off of what ultimately is a preventable disease, we will be faced with an additional avoidable public health crisis once we deal with the acute situation that COVID has imposed. And the only other comment that I would make is to Dr. Pobletti, why stop with just the United States? Let's make the colorectal cancer free zone even broader.
But what's the Dr. Lindberg, what's the direct appeal to the person who's not a specialist, who's not clued into this, that it's worth getting tested, it's worth doing, as unpleasant as, by the way, I think people exaggerate the unpleasantness of a colonoscopy, and that might be helpful for that to be put out there, that it's basically far from a traumatic experience. But to get across to people who might be hesitant without having to resort to scaring them, what's the sort of, the bumper sticker that gets them to be part of the solution to this problem?
Yeah, so to me, the simplest message is just get screened. There are multiple options. One size does not fit all. We've learned that through experience, but there is an effective option that will meet the needs of really all patients and providers. So having that discussion about what tests are available, endorsed, acceptable to that patient-clinician conversation, that's where it has to start. Now, having an at-home test like Cologuard or another stool-based test is not enough. Even completing that test, if the result is positive, a follow-up colonoscopy is part of the screening process and needs to be understood and completed. So how do we get beyond the barriers of not even initiating the conversation? We have to recognize that colorectal cancer has been called one of the most preventable yet least prevented diseases. We all have, elements of our healthcare that require some level of commitment, and whether that's going in for an on-site screening evaluation, whether it's having a blood draw, whether it's collecting a stool sample and submitting that for colorectal cancer screening. If we understand that the benefits far outweigh what I'll say is the inconvenience for some of these, then I think it's easier to get patients and clinicians engaged and hopefully have fewer incident and fatal cases of colorectal cancer.
Dr. Gray, you're at the Ohio State Center for Cancer Health Equity. Where does the colorectal cancer issue fit into the overall picture of health equity?
Well, I'm so glad that you brought up equity because that's an important part of this discussion. And certainly we're now on the tail end, actually just finished the National Colorectal Cancer Roundtable annual conference yesterday, and we talked a lot about equity. And equity for our viewers means ensuring that everyone has a fair and just opportunity to be as healthy as is possible. And to achieve that, we understand that there's some populations that will need targeted interventions. We talked about African Americans as one population, but certainly people can be geographically isolated. We think about our rural Appalachian populations here in Ohio as well. And so as we think about what we can do, number one, certainly we have to target interventions to certain populations. I think about what we do around patient navigation. So ensuring that we navigate people beyond barriers like Paul was mentioning, that they have to getting screening. And those can be transportation. They could be access to care. They could be the access to referral. It could be even having a phone or internet to get the call or notice that they need to be screened, right? I think about ensuring that we diversify our workforce, because we know that diversity drives excellence and innovation. Diversity matters to our patients, and it matters to patient care and outcomes. And so part of what we're doing here at Ohio State as well is we have a summer scholars program trying to generate the new generation of scientists who reflect the patient or the population really of America. We want the face of cancer research moving forward to reflect the face of America. And certainly we're also trying to ensure that in the immediate sense, we are guiding people to getting colorectal cancer screening. We have programs here that allow people, for example, if we take colonoscopy as one example of a screening test, to get colorectal cancer screening if they are uninsured or uninsured. And we do some of this work around Colorectal Cancer Awareness Month. So we have a plethora of activities. I'd be happy to elaborate more if you give me the time.
I wish we had the time. We're close to the out of the clock, and that's why I wanted to go to Dr. Poblete one more time. Dr. Poblete, you've set a really high bar that you also are saying we can get over. But we've talked a lot about awareness in this conversation, and mostly awareness among the patient population. Is there a challenge for getting awareness among the policy-making population as well, or do you think that sector is taking this seriously?
I think that sector is taking this very seriously. And, maybe this is one of the COVID silver linings. The fact that colonoscopies and biopsies have decreased 90% if you compare year over year because of the pandemic, everyone is realizing that this is a significant problem. And if we don't collaborate, if we don't work together, we're going to be in a pretty bad situation. So I think the call to action is really critical to this movement. And just to answer a question that I wanted to jump in on, the best test is the test that gets done. And with the stay-at-home orders, we need a convenient and accessible test that individuals can do in their homes. And the biggest barrier for these targeted populations, if it's the test, the cost of the test, we hope that through our grant, we will be able to address those low-hanging barriers.
All right, Dr. Poblete, thank you. Dr. Gray, I'm sorry about the time, but another time in the future. And Dr. Lindberg, thanks for all of you for shedding light on this topic that really is important to all of us. All right, before we begin our final conversation, we have one final polling question. It's this, it's simple. Have you ever been screened for cancer? That's it. Have you ever been screened for cancer? Just go over to the poll site and cast your vote. All right, we have one more interview, and it's with Fran Drescher and Dr. Beth Carlin. This one was pre-recorded, and here is my friend Jean Meserve with that interview.
Thousands of women each year are diagnosed with gynecologic cancers. What do the case numbers look like? Are diagnostics getting better? Joining me to discuss is actress, uterine cancer survivor, and founder and president of Cancer Schmancer, Fran Drescher. Also joining us is Dr. Beth Carlin. She is a professor of obstetrics and gynecology at the David Geffen School of Medicine at UCLA. Dr. Carlin, thank you also for being with us. Fran, let me start with you. You were diagnosed 20 years ago with uterine cancer. First of all, how's your health? How are you doing?
Thank God, knock wood, I'm doing great. And I'm very grateful. And, I've turned my pain into purpose. And somehow that has made sense out of the senseless and got me on a whole trajectory of living a very pristine, toxic-free life and learning how to balance my stress and, so many things that factor into dis-ease of the body. And of course, I go see my oncologist, Beth Carlin, once a year at least. And she's kind of my doctor for life now.
Dr. Carlin, let me ask you about the numbers. Are you seeing more diagnoses of uterine cancer and other kinds of gynecologic cancers?
Sure, Jean.
Unfortunately, when we look at the success that we've had as a nation in our fight against cancer, uterine cancer is one that continues to increase year over year for more than a decade now. There continues to be a rise in the number of cases of uterine cancer diagnosed in the United States and around the world. And unfortunately, we're also seeing a rise in the number of deaths. So despite the fact, I mean, Fran is cured of uterine cancer. But despite the fact that most women are diagnosed with early stage uterine cancer, we are seeing a more aggressive type more frequently. That is.
Why do you think that is? Why do you think that is?
Yeah, it's part of it is there's a shift in some of the genetics and the folks who are at risk. The most common type of uterine cancer that's curable is often related to hormones. So obesity and our obesity epidemic in the US is part of the main reason for this rise. However, we're also seeing a rise in these, what we call type 2 cancers, due to a number of toxins in the environment, as Franz noted, but really genetics. And those toxins, what I mean is that they change the way the genes that would drive these cancers interact, and they don't stay limited to the uterus, which is when they're curable, but they can metastasize quite early. And our treatments yet are not able to affect cure in those situations.
Do you see that certain populations, you've mentioned obesity as a risk factor, but are there certain populations that appear to be more susceptible?
Well, we're seeing while there's a rise overall, we're seeing even more of a rise in the African American community. It's about 1% per year in the white community, but almost 2% per year in the African American community. Some of the incidence changes have to do with access to care and an awareness of the symptoms. And that's, again, why we're here today. Fran really was a great advocate. She knew something was wrong. And she made that part of her purpose to go find out what was wrong with her body.
Fran, I'm curious about that. I think most women know how to check for the symptoms of breast cancer, but many women, including myself, ignorant about the signs of gynecologic cancer. Why don't we know more? And what are you doing to change that?
For many women, when it's at the earliest and most curable whisper stage, it's very often misdiagnosed for other more benign problems. And this is particularly prevalent with gynecologic cancer. So I was misdiagnosed for 2 years and 8 doctors for a perimenopausal condition that I didn't have, when all the while I had uterine cancer, but I slipped between the cracks because historically I didn't fit the profile of a woman who I was really too young and too thin to be seriously considered for uterine cancer, even though 1 in 4 women are young and thin. And I just want to go back for a second to what Beth said, because she mentioned that it's a toxic environment that could be stimulating the genes to act out in an unfavorable way. And I just want to expand on that for a moment, because genes have at least 28 different ways, a single gene, to express itself. So the more you exacerbate your health and well-being by exposing yourselves to a myriad of different toxins each and every day, with the food you eat, the personal care items that you use, the cleaning and gardening products that you use, that's just the tip of the iceberg. The more you continuously do that, the more you're at risk of the gene expressing itself in an unhealthy way, if it has that eligibility for that. So I think that in many ways, there is absolutely no downside for us all, no matter what your gender, no matter what your ethnicity, to really start looking at how you live. Because as we say at Cancer Schmancer, how you live equals how you feel, and you are what you eat. So, that definitely needs some looking at. And even though we're not talking about uterine cancer, I mentioned gynecologic cancer, and a lot of women are equally misdiagnosed for ovarian cancer, which is far more aggressive. Beth will tell you that one of my girlfriends she cured with ovarian cancer. And at that cancer's earliest and most curable whisper stage, it's very often misdiagnosed for IBS, because at the cancer's whisper stages, that's kind of what it looks like. And a lot of doctors say, oh, it's IBS. They start treating you for IBS.
Friend's been a good student. Yeah, she's been a good
So,
student.
Dr. Carlin, obviously early diagnosis is key. And as Fran has just spelled out, a lot of the symptoms, it could be a symptom of something else.
Are not
so the question is, are the diagnostics getting better?
They're getting somewhat better, Jean. A lot of it still relies on patients coming forward, having access to care. For uterine cancer, the most common symptom is abnormal uterine bleeding. After menopause, you should not be seeing pink on toilet tissue. Women are very used to pelvic symptoms, or they get used to it because they've dealt with menstrual cramps perhaps over years, or they've been pregnant and dealt with, the pregnancy changes, and they often ignore some of those things as just physiologic, and they really aren't when you get past menopause. The diagnostics have greatly improved, believe it or not, for cervix cancer, which is, not a very common disease. We now almost think pap smears are going to become obsolete, because cervix cancer can be diagnosed with an HPV, with a screen of the DNA in the vagina. So that's a huge advance. For uterine cancer, there aren't a lot of new diagnostics. It's really the awareness of coming in for the bleeding and then having a biopsy, which is a simple office procedure. Simple for me and not too hard for the patient either. For ovarian
what about
cancer,
genetic screening? Would genetic screening be useful?
Incredibly helpful. We're not ready yet for population-based screening, meaning everyone when you go into your doctor should have your genetics. I think we're heading in that direction. It's really about, can we target it? I think one of the most important things we can do, and as we now think about Thanksgiving, we may be Zooming with families, is to know your family history. It is so powerful. Over 20% of ovarian cancers are related to inherited genetics, and about 13% of uterine cancers are related to inherited genetics. So that can really be a key. There's certain populations that should have the genetic testing done. Those who are of Eastern European Ashkenazi Jewish heritage have a higher risk of carrying some of these genes. And the United States Preventative Services Task Force has come out and suggested that men and women in that population should at least consider having testing for the genetic risk.
Is it accessible and is it affordable?
So yes and yes. Yes and yes. So it is very accessible. It can be done even by saliva. So in these times of COVID, when we speak to men and women who meet the criteria, all it is really spitting in a tube and mailing it in. The DNA cells that come out from your cheek are just as good as a blood test. Affordable, if you meet the national guidelines, insurers do cover it. There are some challenges at times with folks who are underinsured or uninsured. Many of the testing companies will provide that testing. One point of caution, if I may quickly, some of the over-the-counter direct-to-consumer genetic testing that we see in the pharmacies and all don't test completely for the cancer-causing genes. And when they do, they only test for 3 changes in the Jewish population. So they don't test, those results don't help you at all if you're not in that population. And in fact, those tests are not at medical grade, so they would need to be confirmed before acting on them.
Beth, can I ask you a question? Beth and I, by the way, went to Washington and successfully got the first Gynecologic Cancer Education and Awareness Act passed. by unanimous consent, which means all 100 senators said yes. And I have tried to get the transvaginal ultrasound as part of basic healthcare, gynecologic healthcare for women, because what are your thoughts on hyperplasia as a precursor for uterine cancer? And I don't believe that the traditional, what I think is pretty archaic at this point, bimanual, abdominal thing is accurate, but at least maybe with a ultrasound.
So, Fran, so what Fran's referring to, everybody, is that every month when women have a period, the endometrium, which we're talking about as the cause of the cancers here, is the lining of the uterus, and that sheds off. If it doesn't shed off because you're postmenopausal and it keeps growing, it's like having a lawn that's not mowed. So it's hyperplastic. It has these very long glands that can then become malignant. It is a pre-malignant state. We have studies for over 100 years that demonstrate that. That's usually what leads to some spotting and allows us to make this early diagnosis. So that's why it's so helpful. Transvaginal ultrasound is not a standard of care because of all the false positives and its lack of sensitivity and specificity for getting the cancer diagnosis. I think it is much better than a bimanual pelvic exam, Fran. You're absolutely right. And I don't know how much a screening pelvic exam necessarily helps.
Well, if you saw hyperplasia before bleeding, maybe that might prompt you to do an endometrial biopsy.
Yeah, I think the gold standard is always saving lives with these interventions. So will the screening test translate not just into finding the cancer a bit earlier, but does that indeed translate into more cures? And we're still fighting that, figuring that out with mammograms and PSAs. We know pap smears or cervical cancer screening really does save lives. And that really is the gold standard. But just seeing what we call a downshift in stage doesn't always translate into saved lives. And we're still working on that. Clearly, we need something better than just a pelvic exam.
We're almost out of time, but Beth, at the beginning, you mentioned that the mortality rate is going up for these cancers. Why? Why is it continuing to go up if you're diagnosing them?
Because we're seeing many more of these type 2, well, for this diagnosis of endometrial cancer, we're seeing many more of these high-grade tumors that that metastasize early. So even though they present with the spotting like the others, under the microscope, there are different cell types that spread very early. And we just don't have good treatments, adjuvant treatments. We need more funding for research. I will put in that plug, because that's really where the answers are going to come. Right now, we do have chemotherapy, radiation, and some targeted treatments, and they are allowing women to live longer, but they're not affecting cure.
And there, unfortunately, we have to leave it. Dr. Beth Carlin, Fran Drescher, thank you both for joining us.
Lots of room for hope.
Thank you for doing this, and we're
take care.
To be a part of it.
And to view the final results of our polling questions, just click back over the poll and you'll be able to see those. I want to give a big thank you to our moderators and our panelists, and of course to our underwriters, Bristol Myers Squibb and Amgen Oncology. And thanks also to all of you for watching and for putting in your wonderful questions. We would like to hear about your reaction to what happened today. We'd love your input. We could use it in designing future programs. So there are a couple of ways you can do that. One, click on the chat on your screen. You will find a survey there. Also, you will be sent a survey via email when this event concludes. Please take the time to complete it. And please visit theatlantic.com/live to learn about upcoming events. We were thrilled to have you with us here today, and we hope you'll consider, if you aren't already, subscribing to The Atlantic. I'm Jean Meserve. Stay well, stay healthy. Bye-bye.